Conference will now be recorded.
Yeah.
This conference
Yeah.
will now be
Yeah.
recorded.
We're always learning stuff.
Yeah. There's a lot of things I don't know.
All right. So this chapter is tough. The information in it, you're not gonna grasp all of it the first time. You're gonna have to look at this stuff multiple times. That's what these handouts are for. So make sure you pay attention because
So this chapter covers like everything all at once, and then as we go into different systems, like the respiratory chapter, it's got a deep dive into like the lungs part. So this is kind of just a general like, here's everything, and then we'll go into more of it later.
Will the test for this chapter be on Saturday or Tuesday?
Tuesday.
Awesome.
We only do tests on Tuesday and Thursday.
All right, A and P. Everybody's favorite subject. So the objectives: review commonly known landmarks on the body and illustrate how landmarks you already know may assist you. Comprehend the physiology of shock and how it can be detrimental. I think I told you guys at the beginning of this class, you're going to hear the word shock and hypoperfusion a million times. So we're going to go over it in every single chapter. So it's important to know what shock is, and then identify different body systems and their components. So we have our musculoskeletal system. So we just went over medical terminology. So musculo meaning muscles, skeletal meaning the skeleton. So it gives our body the shape that it has. Without our musculoskeletal system, we'd just be a bunch of sacks of meat. So it gives us, we're technically sacks of meat as it is, but sacks of meat with shape. It protects our vital internal organs, and then it provides our body for movement. Does anybody remember what kind of muscle sits on our musculoskeletal system? Huh? So there are voluntary muscles, but there's another name for it. It's just skeletal muscle. Skeletal muscle or voluntary. Skeletal muscle is voluntary. So our skeleton, obviously we have our skull and our spine, so that sits up top. And that's in there. Our skull is an enclosed capsule, right? So if we have an injury inside of our skull, that pressure is going to build up inside of our skull. There's nowhere for it to go except for one place, right? Does anybody know the one hole that our brain can escape out of on our skull? It lives right here. It's by our occipital bone. It's called our foramen magnum, which I'm pretty sure is just Latin for big hole. So I remember it because if you're digging a hole at a mine site, you're always going to have a foreman watching you dig that hole. So foramen magnum. We have our ribs and our sternum. So our sternum is connected. This picture's hard to see, but our ribs are connected to our sternum by cartilage, right? Then we have our shoulders and upper extremities, and then our pelvis and our lower extremities. So our body structure of the head, skull. This came right out of your book. On your guys' little things that I handed out earlier, it's this picture. So the answers are in the book. So it protects our brain. It encloses. We have our little fissures here that they close. We learned within 2 years of being born. You have your cranium, your top, back, and sides, and then we have different parts of our brain. So if you're describing like an injury of the head, like if they have a big old knot here, that'd be like your temporal, right? So it's important to know what's where. So we have our frontal, parietal, occipital, and then our temporal over here. So it's important whenever you're describing an injury, like over the radio or something, like, hey, he has a big old hematoma above his temporal bone. It just makes it easier for everybody to understand. And then we have our face, the front of the skull. So our zygomatics are cheekbones. So we have our like their arches, so our zygomatic arches. Then we have our mandible. Our mandible is a movable mandible. And then our maxilla is on top. It's the one that doesn't move, right? So whenever we get into like our trauma parts of the book, we're going to learn about Le Fort fractures, and there's Le Fort 1, 2, and 3. So that's just describing where their face is broken. So it's kind of important to know what's where. So then we have our spinal column. So we have 33 that encase the spinal cord. Our spinal cord is very, very wimpy. I know it does a lot of things, but just dropping a dime on your spinal cord itself could sever it. So it needs protection. So that's our vertebrae, right? So we have 33 of them. And then it is essential for movement, sensation, and vital functions. So our nervous system branches off of our spinal cord, right? And that's what allows us to feel things. It allows us to move, and it allows our body to do its vital functions, right? So all of our organs are innervated. So they all have nerves that attach to them. And those all come from the spinal cord. So thorax, we have 12 ribs and a sternum, and that protects our heart, lungs, and major blood vessels. Our major blood vessels are all kind of encased in the sac, right? When it's talking about major blood vessels, we're talking about the aorta, we're talking about the vena cavas. And so all of that sits in something called a mediastinum in our chest.
What's
What's
it called?
a mediastinum, mediastinum. So all of that sits in our chest, a little bit off to the left, depending on who you are. Some people have it over here, some people it's fluid. That's the oddities, right? So this is how I remember these. There's a little saying, can this little server cook? So you have your cervical, your thoracic, I can never say that word, lumbar, sacral, and then your coccyx, right? So our coccyx is just our little tailbone down at the bottom. And then our hip, our pelvis attaches here on the sacrum, and that's called an SI joint. So it's sacroiliac joint. So all of that is just putting all these words together. It's how I remember how many are in each. So we eat breakfast at 7, we eat lunch at 12, dinner at 5, and then we eat 5 tacos before bed. So that's how many vertebrae are in each little section here. So 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and then the coccyx is just 1. Oh, it is 4. You're right. I'm sorry. 5 tacos before bed. Before number 4. That's supposed to be a number 4. My bad. My brain's fried today. Then here's our skeletal system. So it's kind of important to know which bones are where. Because if you hear somebody say like, oh, they have a humeral fracture, what is fracture? What part? It's up here. So this is our humerus. Close. So it could be a distal humeral fracture. And then you have your radius and your ulna. So we feel a radial pulse against the radial, right? So here is our radius, and then our ulna is on this side. So you feel a radial pulse against the radius, and then the ulna is over here. You actually have a pulse over here. Kind of hard to find though. And our patellas are little kneecaps. What's the Nutella thing you were saying earlier?
Nutella patella.
Nutella patella. And then our toes and fingers are both called flavies. So that's fun. But then you have your carpals and metacarpals on your hands, tarsals and metatarsals on your toes.
And the palms are what? And then these are the planters.
So palmar and then plantar. So the ilium, ischium, pubis, hip joint. So the ischium is your butt bone. That one's like kind of behind here. Or it's like right in the center. It's your butt bone. And then your hip joint, where your joint actually comes into your pelvis, that's called your acetabulum. So a lot of times with like our older folks that fall or break their hip or break their femur, most of the time they break right here. And so they'll just break that off completely. And that's usually what they replace whenever you go into like your hip surgeries and stuff. That's what they'll replace. So when it says ball at the proximal end of the femur, what's proximal? Closer to the floor, right? Yeah. Good. So then our femur is our big bone here, right? That is hard to break unless you have something like osteoporosis or something. That's one of the most difficult bones to break. So if somebody is breaking that, that means that it takes a lot of force to break it. This is important whenever we start talking about something called a mechanism of injury. So what caused their injury? If their injury was like strong enough to break a femur, they probably have more stuff going on than just a broken femur internally that you're not going to be able to see. All right, unless it was something like just their leg was ran over. But if you like are going out on somebody that was in a car accident, especially like a kid, and their femur is broken, it took a lot of force to get that femur to break. So have a high index of suspicion of other things going on. Patella, Nutella, I like it. So our tibia is our big bone in our bottom of our leg. As you start progressing in EMS or healthcare in general, the tibia is important to know because that's where we drill whenever we start veins in the bones called IOs. We drill into the tibia. Then your ankle, everybody knows the medial malleolus because everybody's hit that thing on a scooter. A kid. This little bone right here, your malleolus, the medial is the one on the inside, right? Because that's medial. And then lateral is the one on the outside. And everybody's hit that thing and it hurt. So, yeah. Our tarsals, metatarsals, and then our phalanges. So our toes and fingers are all phalanges. I just like that word. It's fun. So another one, calcaneus. I'm sure there's another way to pronounce it. I've always pronounced it calcaneus. That's our heel. All right, so our upper extremities, we learned the other day, clavicle is our collarbone. So when we start talking about like mid-clavicle, is in the middle of our collarbone. Our scapula, we know, is our shoulder blade. The acromion is how I remember the bird on your shoulder. It's acromion. It's right up here. So then you have your acromioclavicular joint, and that's right up in here. And then that comes down into our humerus, which is the upper bone of our arm, and then radius ulna. We have our wrist, hand, and that's our carpals and metacarpals. And then it goes out into our phalanx.
That's the rotator cuff.
I believe it's on the back side over here, like up in this area, but on the back, because it is allowing you. I don't know the official name for rotator cuff, like in medical. That's something I'm gonna have to Google. I've always just heard it rotator cuff. So different kinds of joints. We have an elbow hinge joint. That one's pretty simple, right? Our elbow can only move one way. We're not moving it back, right? And we have our ball and socket joint. That's like your hip joint where you can move it forward, backwards, to the side. And then we have other joints in here called a hand gliding joint. And that's what allows your thumb to move as it does. So different kinds of muscles. We have our voluntary muscle, which is skeletal, our involuntary, which is smooth. I'm talking about the muscles that line like our intestines and stuff that allow us to digest food. So all of our intestines are always moving food around, right? And you don't have to think about your food moving through your digestive system. Then you have your cardiac. Cardiac muscles are special because they have automaticity. What that means is they're able to direct electricity through their muscle, and that's what allows your heart to beat, right? So that's what we're looking at whenever we pull up like a 4-lead or a 12-lead, that picture we were looking at out there. That's what it's reading. It's reading the automaticity of your heart.
Whenever someone's doing like they whenever like when they're in cardiac arrest, their heart is freaking out, some electrical pulses in there.
Yeah, so there's a couple of different rhythms that like a heart could be in to shock it. One of them is called VFib, and that's what the heart does. It just sits there and quivers. There's no rhyme or reason to any of that electricity that's going through it. And then there's another one called DTAC, and so it can either have a pulse or not, but same kind of thing. At heart, there's no rhyme or reason to it. And so you're trying to shock, it's basically you're turning it off and then back on again by electricity, which we have a medication that does that too, but it's more fun to shock someone. Just saying.
It's fun faster, right?
Yeah, so, well, Dennison, you have to get the IV started, you have to slam it. And then if someone's in cardiac arrest, I'm not worried about medication to restart the heart, I'm just gonna shock it anyway. All right, our respiratory system, so brings in oxygen via inhalation, right? So that is our ventilation. So there's a difference between ventilation and oxygenation, and we're gonna deep dive into that in the respiratory system PowerPoints. But inhalation, so ventilation is the movement of air in and out of your lungs. So whenever we breathe in oxygen, right? The air is what percentage oxygen? Roughly. 21% oxygen. So it's not very much. The rest of it's like other gases. So we breathe in 21% oxygen, and then we breathe out carbon dioxide. So whenever we start talking about end tidal, like CO2s, they actually measure the carbon dioxide, which is pretty cool. We'll learn about like the normal things, normal numbers that you're looking for. So up here, you have your pharynx and larynx. Your larynx is basically your voice box. That's where our little vocal cords sit. If there's ever a question saying what differentiates your upper airway, what structure is the turning point from the upper airway to lower airway, it's your larynx. So it's right in here. From this point down, it's lower airway. From this point up, it's an upper airway. So that's right in here. So you have your oropharynx, and then you have your nasopharynx. So what do you think that means? What is naso?
Mouth or nose.
Mouth or nose, good. So naso. And so whenever we start talking about certain airways that we use, we have something called an NPA, or a nasopharyngeal airway, goes in the nose. And then you have the OPA, which is an oropharyngeal airway that goes in the mouth. Usually. Let's hope they go there. I've seen some weird things. So then you have your trachea. So our trachea up here, does anybody know what this structure is here?
That's the xyloid. No, that's the Adam's apple.
It's the Adam's apple. So it's your thyroid cartilage. And then you have your cricoid cartilage right in here. So then this little spot right here where the green is, that's your cricothyroid membrane. So your trachea has a bunch of little rings in it. So whenever it's not easily collapsible in an adult, right? So in kids, these little rings, it's important to note, and you're probably going to get a test question about this, but those cricoid rings are not developed in kids yet. So their airways are super easily collapsible. So that's why we're careful about how we open airways in kids, because you can just pinch off their little airway so easy. It's like the size of a drinking straw. It's so small. So then our bronchial tubes, like we were talking about earlier, you have your bronchi that reach out into your bronchioles, which reach out into your alveoli. And then all of that is inside of our lungs. So our lungs exchange oxygen into our bloodstream.
One of these Saturdays, we have a set of lungs that we'll get out and actually ventilate them and show you how a lot of stuff they'd be close to whenever we actually get into the respiratory. We also have a heart that we're going to cut open and look at. So, maybe this.
Calvin and I always argue because I think that hearts are cooler than brains, because I just like heart stuff. And he's the neuro guy, so we always argue back and forth. Because hearts are cooler, really. They are. So. All right, so this is the kind of the flow of things through our respiratory system. So our air enters our body through our mouth and nose, or mouth or nose. Where does it go next? Into the oropharynx, right? Oropharynx, nasopharynx. Whenever we're talking about the pharynx, we're talking about both of those systems, the oral and nasal. And it moves towards the lungs. We have this little structure that sits over our trachea, and it's called epiglottis. It's floppy. But whenever we breathe in, it allows the air to go into the right hole, right? And same thing, whenever we eat, it covers our little trachea so we don't actually physically inhale our food, right? So epiglottis. In kids, this likes to get inflamed. They get something called epiglottitis. We'll talk about that. So whenever you take a breath in, it opens, and then as you like eat or something, it's going to close over your trachea to stop the food from going down in
That when people say you went down the wrong pipe, that they did close.
there. Yeah, basically. So just beyond your epiglottis is your voice box. So we have little vocal cords that sit there. And that's where it turns into the lower airway, right? Goes into our trachea, and then down into our lungs, our bronchi, our bronchioles, and then our alveoli. And then what structure assists us in breathing that sits right here? Diaphragm. Good. Now, whenever you breathe in, does your diaphragm go up or down? It goes down. So it's gonna use a negative pressure system. And I wish I had my little bottle. I'll bring it on Saturday. So whenever our diaphragm pulls down, it uses negative pressure to pull air into our lungs. And then as it relaxes, it comes back up and pushes the rest of the air out. I think this is a video talking about the anatomy of like the larynx and stuff.
Hello, I'm Ross Anderson.
He has a fun accent.
To dissect the lungs. So our lungs can be found just behind our ribs inside our chest, and they're responsible for exchanging the gases between the air and our bodies, getting rid of the carbon dioxide we don't need and taking in the oxygen that we do. So that oxygen is carried around by the blood in our bodies. It needs to be pumped by the heart. And we can find that just behind the lungs. When you breathe in, the air passes through your nose and mouth, rising at your throat, where you can find this thing here. This is called the voice box or larynx. And attached, you can find two tubes that go down. This one here goes down to the lungs, called the windpipe or trachea. And here we have the esophagus. So you want your air to go down here to your lungs, and your food to go through the esophagus. This is called an epiglottis. When you swallow, it closes over the top, blocking the trachea, preventing any food from going down. So instead, your food just passes in the esophagus. So now we're going to remove the voice box.
Are we gonna have all those?
So inside here,
I think, I'm pretty sure that they're there.
together.
They were donated to us by one of the butchers.
And whenever you want to make a sound, all you need to do is just vibrate.
So it's not
And
human.
you can feel this for yourself by
Huh?
placing
Since
your
it's not
hand
human.
on your throat.
It is not
Going,
human.
and combined with your lips and your tongue, that is how you speak.
They gave us cow lungs
So the
last
air
year,
passes down the trachea.
and we were trying to
towards the
innovate them, and we used the largest tube that we have, and it still didn't fit, so.
So these rings of cartilage help keep the windpipe open, giving the air a clear passage going down to your lungs. But if you know anyone who suffers from asthma, these rings of cartilage can collapse down, preventing the air from getting a clear passage down. But if you take an inhaler, breathe in that medicine, it will open back up, meaning they can breathe properly once again. So let's cut down the trachea and see what's inside. Inside here, you can see this foamy stuff, and this is the mucus. You have mucus in your lungs too, and it helps to prevent any bits of dust and bacteria from getting into the lungs. So when we get to the bottom of the trachea, we can see that it branches off the two tubes called a bronchus. So the air passes down here, going into the lungs. So let's cut down one of these tubes. But just like the branch of the tree, these branches get smaller and
I think working now. Did you have it hooked up? All right, let me know if it's back.
What is that white blob in the heart, in the left ventricle?
That's your mitral valve.
So it actually looks like that.
Yeah. It's like, it's got 3 flaps on it. They open and close.
And that's
Yeah, my wife sleeps.
Huh?
My wife sleeps,
Oh, really? That's not good.
so she's on medication for
Interesting. I watched a YouTube video the other day, during a heart transplant. Apparently, they are genetically modifying pigs now, so they can put pig hearts in people.
Yeah, just kind of flapper.
Oh, really?
Yeah.
Huh. It's so interesting to me.
My uncle has been doing much better since.
Like a whole heart or just a valve? That's so
I
cool.
don't know, I mean, I was like 14, he was like 16 when he got it.
Yeah,
We're very close in age.
yeah.
But
That's
I'm not in
interesting.
contact with him.
Oh, really? Does it work now?
Yep.
Oh, okay, sweet. Okay. So respiratory physiology, oxygenated blood comes from the lungs back to the heart and then goes to the rest of the body. At the cellular level, oxygen is exchanged and CO2 is exchanged. So CO2 is like our body's waste. That's what our metabolism is then metabolizing. It puts CO2 back into the blood and then we breathe it out. So, and then the deoxygenated blood returns back to the heart to start the cycle all over again. So, lung problems can cause heart problems. Heart problems can cause lung problems. It's all just one big happy family. So any mess up in one part of our system is gonna affect all of it. Basically, air goes in and out, blood goes round and round. Any deviation is a problem. I'm pretty sure that's on one of these slides. Now my clicker's not working.
Oh. Yeah.
I love technology so much.
Yeah. Try that.
It's working.
Oh, there's a mouse.
Okay, so we were talking about the kids. There's a mouse on the screen. So kids, everything's a little bit smaller. Their tracheas are teeny tiny. And children have ginormous heads. I don't know if y'all have ever noticed that. So whenever you lay an adult on their back, their head kind of sits a little bit in line. But kids, because their heads are so big, it's actually gonna just like close their airway off because the back of their head shoves up and their airway pinches off. So whenever we,
Actually, if you even look at this, you kind of have that same effect with adults too. That's why whenever we stick tubes down people's throats, we pad up under their shoulders too, to try to inline some of their stuff. It's not as aggressive with adults as it is with kids, but it does happen with adults too.
yeah.
So do you typically do like Fowler's or semi-Fowler's for children?
For kids, we do something called a sniffing position. If we're laying them flat on their back, we take blankets, a pillow, anything, and shove it up under their shoulders to bring their head back into like a neutral position. If they are laying on their back, I mean, not every kid that's sick on the ambulance is gonna be laying flat. But if we do, we'll talk about it more on Saturday in your CPR class too, that you want to put them in that sniffing position, or else you're gonna have a hard time ventilating them. If you're ever trying to bag a kid or an adult, but usually kids, if you're trying to bag a kid and you just see their belly getting bigger and bigger, you need to readjust their head because something's pinched off where it doesn't need to be pinched off. All right, our cardiovascular. So cardio meaning heart, vascular meaning veins, right? So we have 4 chambers of the heart. What are the 4 chambers?
Right.
Right, so the atriums and ventricles, right? And remember, this is always going to be the patient's right. So if you're looking at a heart, it's going to be opposite. So. And then we have our 4 valves. What are the 4 valves? Those are vascular. That's the vasculature. What's the valves? We're talking about these little valves here. All right, so we have our tricuspid, we have our mitral or our pulmonary, also known as our bicuspid valve, our mitral, and then our aortic. So this is also known as our tricuspid because it has 3 flaps, and then pulmonary is known as bicuspid because it has 2 flaps. They were really, really original there. And then our aortic valve. So the way I remember these, toilet paper my ass. I remember them. So that's the order that they go in. Yeah. So fun fact, whenever you're listening, if you ever like put a stethoscope over someone's heart and you're hearing lumped up, lumped up, lumped up, lumped up, it's actually those valves closing is what you're hearing. They close so quick that that's what you're hearing. You're hearing those valves shut. So that's the lumped up, lumped up. They open and then they close, allowing the blood to flow as it should.
And eventually we'll get the ultrasound out on somebody that wants to strip for the class. And we could show you all some of these valves with the ultrasound. It's pretty cool to see. We'll probably do it with Marcus since he's so handsome.
It's really easy to do. Like anybody that's really tall and like usually a male because they don't have extra tissue. Oops. And then like skinny, it's easier to find all the structure we're looking for in someone that's tall and skinny. So.
You're still here, so, bro.
Who's willing to, when we get to like the female anatomy, who's willing to come in as ultrasounder?
Oh, yeah, I mean, we can do it on everybody. Whenever we ultrasound like the female, there's only one spot that's really different. So whenever we look at a bladder on a female, so we use the ultrasound here. We use it for something called an EFAST exam. And so what that does is it tells us if somebody is bleeding into their belly or not. And so we look at different parts of the body. So if someone's in a major trauma, we scan their lungs to make sure that they don't have a like a collapsed lung. We check their heart to make sure that they're not getting fluid buildup around their heart. We check their IVC, which is their inferior vena cava, right here. And that'll tell us if they're like losing blood volume. And then we scan the liver, we scan the spleen, and then we scan the bladder. And so we can see behind the bladder if there's blood or not. So the only difference that you're really seeing is girls have a pouch called some doctor's name because he found it and named it after himself. It's not Morrison's the word. And there's a fancy name for it, but you're looking behind the bladder. And for females, whenever you go to scan the bladder, you'll see a pouch behind their bladder, and it's part of their uterus, basically.
She's got a, like she's pregnant, so.
Oh,
But
see a
listen,
little
we will
more.
be more than happy to scan a baby. We're not experts.
yeah, we tried this last year.
Yeah, we,
Because that's what you said, so I asked her if she'd be willing to come in.
yeah,
So,
yeah, I mean, we can try. We're just not, I can find livers and I can find hearts and I can find lungs. Babies are freaking a pain in my.
They're hard. It's funny because, you know, like they say, like, it's like older than 21 or more developed than 21 weeks is like the easiest way to find the ultrasound. We had someone in our class last year at 14 weeks. I had like a perfect picture of her little baby. And as soon as she came in, she was like 34 weeks when she came in the second time. I could not find that baby's face to save my life. I was looking all over. And then I finally found it and the baby did like a flip. And I was like, great. Can't find it now. But yeah, I mean, that'd be cool. Yeah, it's cool to see. It's cool to see.
It is cool to see, but it's difficult.
It is tough, like ultrasound techs have all my applause because it's hard. All right, so pathway of blood. So these blue structures that you see here that say from body, those are vena cavas. So it's the largest vein in our body. So we have our inferior, meaning top or bottom. Inferior, and we have our superior vena cava. Good, so inferior is low, superior is high. And that flows, you can see this little hole right here next to the number 1, and it comes up into our right atria. From our right atria, it goes into our right ventricle. from the right ventricle, it goes up into the lungs. So our pulmonary arteries, remember, arteries always mean the blood flowing away from the heart, right? Every artery in the body carries oxygenated blood except for the pulmonary artery. That is the only one that's an exception. Same thing with pulmonary veins. All veins carry deoxygenated blood, but the pulmonary veins carry oxygenated. So it goes from the pulmonary artery into the lungs at that alveoli that we were talking about. That oxygen exchange happens. That oxygen gets loaded onto our blood. And then it comes back into our left atria, up here where number 4 is, and then our left ventricle. And then from there, it gets pushed out into the rest of the body from our aorta. So it all moves back, goes out, gets deoxygenated in all of our little capillaries, and then comes back to the heart one way or another. And then we have the cardiac conduction system. So these are the little nodes in our heart that allow the electricity to have its own automaticity through our heart. So we start out with the pacemaker of the heart. This is called our sinus node or our SA node. So this, if in a healthy heart that's functioning as it should, this is what keeps our beats, right? 60 to 100. And it tells our heart, okay, it's time to start beating now. From there, it goes through these internodal pathways. And it's important to know that each of these nodes are actually just like little clumps of cells. It's not like an actual string. They're just little clumps of cells. They're a little bit better at conducting than the rest of the cells of the heart. From there, we have our AV node or atrioventricular node. One way I remember like the order of the nodes is the heart is savvy. The heart is savvy. So we have our SA node and then our AV node. From there, it goes into our AV bundle. This is also called the bundle of His or the Hisman bundle. Everyone asks, where's the bundle of hers? And I always say that it's the right bundle because girls are always right. But that's not true. So we have the bundle of His. That's a little node that sits below our AV node or like a branch. And then that branches off into our right and left bundles. So as the electricity comes down, it starts at the SA node. That's our pacemaker of the heart. Goes to our internodal pathways. And it doesn't show it on this picture, but there's another branch that comes around. So our left atria can contract as well. And then it comes down and moves down these branches. And then to get to the apex of the heart, we have something called Purkinje fibers down there that kind of help disperse the rest of the electricity. Another thing that you might see are intraventricular septum. So inter meaning in between, right? Ventricular, ventricles. So interventricular, between the ventricles. That's our septum. So right here. So that might be on a test. Where's the intraventricular septum? It's right there. So right and left pulmonary arteries are the only arteries to carry deoxygenated blood. They're still moving away from the heart into the lungs, but they are carrying deoxygenated blood. Another artery that's important to know is our carotid. Does everybody know where your carotid arteries are? Okay. So whenever we're feeling for a pulse, that's where we check, unless it's in a kiddo. If they're less than 1 year old, we check a brachial artery. Kids, their heads are so big, it's hard to find it anyway. So if you just find your trachea, slide 2 fingers over, you'll feel a carotid. And that's on both sides. Avoid checking both carotids at the same time. You don't want to make someone pass out. And then we also have arteries that surround our heart. So these are called coronary arteries. And whenever somebody's having a heart attack, these are the arteries that get clogged. So you have a bunch of different arteries here. You have your right coronary artery, you have your left circumflex, your left main, and then you have your posterior artery that runs over here. But basically, they just surround the heart. So they get their blood from our aorta, actually. There's this little hole right here. kind of hard to see because this is so little. But whenever this valve closes, the blood pools back up and goes out into our coronary arteries. This is called a coronary os or an ostia. And then femoral artery. So whenever we talk about central pulses, we're talking about either the carotid or the femoral because they're the closest to our hearts. So femoral artery obviously runs all the way down, but you can feel it right in here whenever you go to feel on an unconscious patient. You have your brachial artery. So you can try and find yours. Remember, your arteries always fell where you're pushing the artery up against a bone. So if you're having a hard time feeling it, kind of feel for your bone. And then you'll find like a little notch, and that's where your artery sits. So then our radial artery, right? We're feeling these with our fingers. Never feel for a pulse with your thumb. Whenever you feel for a pulse with your thumb, you're going to feel your own pulse. So use your two fingers. Then you have your dorsalis pedis. So that's going to be on the top of your foot. Good luck finding that. That thing is a pain in the butt to find. I recommend just finding on yourself like over and over and over again. So whenever you have a patient that you need to find a pedal pulse on, it's easier for you to find. So you have one on the top of your foot. You also have another one that runs here behind your like medial malleolus. They can be very tough to find. The most difficult one to find though is your popliteal. So this actually runs right behind your knee. So this one, very difficult to find. I can say in the 10 years I've been doing this, I've never found a popliteal artery by palpating, by like feeling it. I found it with the ultrasound, but that's it. It's hard to feel. So why do you think it's important to like know where all of these distal pulses are? Injuries, huh?
Make sure they're getting blood flow to the extremity.
Yeah, blood flow to that extremity. So if you have like an injury in that leg, you want to be able to find a pulse in that leg distally from the injury. So it's important to know where all of these are. Here's that little thing I was telling you about. So your artery, your arterioles go into our capillaries. These are at all of our tissues, every tissue in our body. So all the way down to our fingertips. This is where oxygen gets let off at all of our major, this is how our body gets blood or oxygen. So the arteries come in, the gas exchange happens at the capillaries. The capillaries are the smallest of all like the vasculature. And then it comes back through the venules and then into the veins, back into the heart. So then our blood. So most of our blood is plasma, more than half of it. So this chart says 52 to 62%. You look up different charts, they all tell you different numbers. It's just important to know that more than half of it is plasma. So then we have our red blood cells. These are what carry our oxygen, right? So red blood cells, erythrocytes, red corpuscles. That's what carries our oxygen. And then you have our white blood cells. So these are what fight infection. They're also called leukocytes. So whenever we talk about like leukemia, they're talking about white blood cells, leuko. And then our platelets. They help with clotting. We have a whole bunch of systems in place in our body so we can clot. Most of them come from our liver. But the platelets kind of start that cascade effect of like, okay, we have an injury, let's start clotting now. So our pulse is the pressure wave through the artery. That's what you're feeling whenever you're feeling for a pulse. We already know that that's like compressing an artery to the bone. And then knowing where our major arteries are. So whenever we talk about core pulses or central pulses, we're talking about carotid or femoral. We already talked about that. So anytime someone's unconscious, that's the first thing you're going to do is feel for a carotid pulse. Then our blood pressure, this is the force against our heart beating blood against our vessels. So whenever you're looking at a blood pressure number, our systolic number is the top number, and then our diastolic is the lower number. So the systolic is caused whenever the left ventricle contracts. That's where the blood goes into our body, right? So that's the last stop before it gets pushed back into our body. And then the diastolic reading is whenever our heart relaxes and is allowing that heart to refill with blood. So it can pump more. Here's that word again. So, perfusion means that the body has adequate blood flow and is getting appropriate oxygen and nutrients on like a microscopic level, right? So then from there, there's waste that our body creates whenever we metabolize, and it gets offloaded. So anytime there's a problem with this in any way, shape, or form, it's called shock or hypoperfusion. Those words are synonymous. So whenever you see, there's different types of shock. So anytime you see the word shock come up, it means that our body is not perfusing as it should. Our organs are starting to die for whatever reason because they're not getting the oxygen and nutrients that they need. Here is a little drawing of a ravioli. So these are those little microscopic things in our lungs that exchange oxygen and CO. So all of them, all of our little raviolis have blood vessels that surround them. So whenever we breathe in, that oxygen offloads onto those capillaries, and then all of the waste that our body has created gets offloaded back into our lungs for us to breathe out. So this is what it looks like, basically. So if there's any problem with the breathing or with the perfusion, this is what we're talking about whenever we start learning about VQ mismatch. Why they call it a Q, I have no idea. Because V stands for ventilation, Q stands for perfusion in their brain. I don't know why they used a Q, why they didn't just say perfusion or use a P. But this is the base of ventilation and perfusion. So,
What did you call it? VQ what?
mismatch, or you want it, it's VQ match. But if there's a problem with one or the other, it's called a VQ mismatch.
Is there any time that you wouldn't give like oxygen or whatever for treating for shock? Or is it just always oxygen and whatever?
So oxygen, its molecule, like the molecule of oxygen itself, can be harmful to tissues. So we have pulse oximeters that read our oxygen concentration in our bloodstream, and it can only read up to 100%. You can have more than 100% oxygen in your blood system. But whenever we start learning about strokes and heart attacks, if you give somebody too much oxygen where there is an issue with one of our vital organs, it can actually build up and cause like problems on a cellular level. So we titrate oxygen to where it's like 94 to 99%. So if they're already at 100%, I'm not going to give them oxygen if they're like in a cardiogenic shock because I can't do blood tests that are like, oh, they're actually at 110% oxygen. So that would be the only time that I'm like really withholding oxygen. They used to teach, my soapbox, they used to teach that COPD patients shouldn't get oxygen because they love this thing called hypoxic drive. In the 1940s, they did a singular study about hypoxic drive, and one dude went apneic, stopped breathing because of a hypoxic drive. They haven't been able to reenact that same scenario. So you might hear somebody say, don't give COPD patients oxygen. In the pre-hospital setting, if they need oxygen, we give them oxygen. So I have a whole soapbox about that. That's the gist of it. But these guys like to get me riled up because they're like, oh, hypoxic drive. And then I'm like, yeah, it is a thing, but it's not a thing that you need to worry
It's not
about.
a thing that we have, that you're gonna have to worry about. It's not a thing that causes people issues in the hour that you're gonna be with them. What that really comes from is patients that live chronically with low oxygen levels, when they're put on ventilators for a long period of time, they will basically send their body into like a vacation, right? Like you've been working for the last 6 months, you go on vacation, you're sitting on the beach with your toes in the sand, your week goes by, you're like, frick, I gotta go back to freaking Battle Mountain, right? Well, your body does the same thing. When you're chronically living in a low oxygenated state from like COPD, and then I put you on a ventilator and I get your body used to sitting at 98%, and you're used to sitting at 89%, Now your body's like, dang, that's pretty nice. Like all my stuff's getting all the stuff, like blah, 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 blah. And now you sit like this for a month. Well, now I just yanked this ventilator off of you and will kill the crap out of you because your body's not going to keep up with that anymore. Your body's going to want to go back to living at 89, but your body's like, no, this is really nice. That's where that comes from. It's nothing you have to worry about. Like Becca said, if their oxygen is fine, let them be fine, right? Because you'll still hear people that's been doing this for 30 years, like, nope, he said he's got chest pain, put him on a non-rebreather, wide open. Don't do that. You're actually causing problems. So just, if their oxygen is fine, they're fine, right?
The reason I have so much beef with the COPD thing, I had a patient, I went to a urgent care in Atlanta for difficulty breathing. This lady had a history of COPD. I walk in and her lips are this color. She's hanging out at like 78% oxygen. And the PA standing there like, yeah, I didn't give her oxygen because she has COPD. I'm like, ready to fight you. So I got beef with it. There's a whole nother slide to a PowerPoint where I did the research so I can let y'all know that it's okay to give people oxygen. How are you guys doing? You need a break? You need a break? Okay. You guys want to take like you can do a 10-minute break, 5-10-minute break?
What is COPD?
It's a chronic obstructive pulmonary disease. So it's an umbrella term, like emphysema falls under that, chronic bronchitis, not bronchiolitis. Falls
Most of the
under all
time
that.
you see it like really bad asthma patients, long-term, or like smokers. Typically are the ones that get it. Kids that are like super sick when they're real young, get a lot of lung issues, typically like develop it later on in life.
What about like silicosis? Would that be considered? Would that fall under like COPD?
Sarcosis?
Silicosis?
Oh, silicosis?
I don't know if that's,
Because it's inflammation of the lungs.
It
due to
might be.
silica.
It might be, because it's just a chronic obstructive. So silicosis is.
It's
obstructive.
discarding, yeah, but it's
Yeah.
discarding that causes the inflammation.
Yeah, yeah, so our vessels are really like odd because chronic like damage to our vessels in any vessel capacity, whether it's our bronchioles, whether it's like our arteries, our veins, it can cause like where our arteries and veins and bronchioles just get hard and they just don't respond as well as they used to, or like they normally would open up so you could breathe, so they can't do that as well. So I'm sure it might fall on that. So
yeah, it's just an umbrella term for lung
Yeah.
problems, chronic lung problems.
Yeah.
Chronic obstruction
yeah.
So if
of the
there's,
pulmonary.
System, yeah. Yes.
if there's someone that's like this COPD and they're on oxygen, are they still only breathing it like that? During
A lot of times they will, right? So like, if you have somebody that's like a chronic COPD patient, you know, they walk around with like their little oxygen bag and all that stuff. But if you stick them on a pulse ox, chances are their oxygen is still only going to be like around like 90, maybe 92 if they're like chilling, sitting still. But what they're doing, right, is so like the doctor, if they're sitting at like 90, 92, and they're like chronically on 3 liters of oxygen, the doctor's not going to make them walk around with like a big face mask just to try to get their oxygen up to 100%, right? Because that's just going to do more harm than good. So yeah, typically if they have like chronic COPD, even with the oxygen on, they'll still sit probably in the low 90s most of the time.
It means.
I went through this too, and I had to call the ambulance.
So
On
if you do this to
he was
me,
breathing, but his lips were
I'm not-
full and I couldn't figure
no,
it out.
Yeah.
no.
So I-
Yeah, and a lot of times, right, so like he could have been having just an exacerbation of that issue, right? So like COPD patients will get that like inflammation in there and it'll exacerbate that problem. And so like he could have been sitting in the 70s, right? So like that cyanosis in their lips, that blue in their lips and on their fingertips and stuff like that. Sometimes they'll sit in like their body's so used to sitting like that they won't get that. But then when they have that exacerbation or like that acute onset that's like worse than normal, that's when they'll get the and like the blues in the fingers and like the oxygen sats will be like in the 70s or even low 80s, you know. So like that's where you see like the exacerbation issues. I mean, that 2 liters of oxygen will do good for them on just like a normal basis, but if they're having like that inflammatory response, that acute response, and that acute exacerbation of COPD, that oxygen, that little bit of oxygen that they're getting won't help them. That's when we put them on like the big mask, give them BiPAP, you know, dump a bunch of meds into them to try to get that inflammation down and like start reoxygenating the body. And even then, like we won't put them on a bunch of oxygen for a long period of time. We'll start like getting them to turn around and then titrating it all back down because we don't want their body to get used to that really nice oxygen for a long period.
What does BiPAP stand for?
So you just.
Biphasic, positive,
Ambulance attendees come out.
biphasic, positive airway pressure.
I'm not. I don't know what
So all it is a 2-step system. So like CPAP is continuous positive airway pressure, so it's just like a continuous push of air. Yeah, BiPAP has an inhalation and an exhalation phase. It's got 2 phases to it.
And that's the pink thing on your reader in the ambulance?
No, that's entitled.
That's entitled. And what's a normal entitled? It's like
35, 45.
35?
Body weight and stuff. It makes you happy.
Is that like a percentage? Or what is it measuring? It's millimeters of mercury. So it's measuring the exhaled carbon dioxide of the lungs in milliliters. And it's in millimeters of mercury. Yeah, so it'll give you like a graph. And then it shows you like how much they're exhaling at a certain point. So if you actually watch the graph when someone's breathing into it, you can tell if they're like bronchoconstricted, like they have asthma. It'll change the shape of the graph.
I thought it was.
He's like,
what are you doing?
Oh, yeah, CPAP's fine. Most patients don't really tolerate CPAP very well. They prefer BiPAP because CPAP's like sticking your head out of a car window and like constant air.
Yeah.
And then BiPAP is a bi-level. Yeah, so it's a 1 pressure of air, and then as they inhale, it triggers like a second like of air, and then as they exhale, it's not working as hard against it. Okay. Within 5 minutes, I'm back at time. Okay. Who in here has ever had a swollen lymph node?
Everybody.
Yeah, it sucks. Yeah.
It's been swollen for 4 years. Oh, shit.
Oh, that's good. Good. Okay, so our lymphatic system, it is there to protect our body from like inflammation, diseases, those kinds of things. It's like a filtration system. So if you've ever had like swollen lymph node, usually they happen like right around here. Sometimes they happen like around your collarbones. They'll happen behind like your neck. Pretty much like when I got my tattoo done, this one swelled up just because it's like trying to filter out like any kind of bad things. And my body's like, no, you don't need a tattoo, and it gets swollen. So they also maintain the balance of fluid. So whenever we start talking about like fluid buildup in the system, the word for that is edema. So EDEMA. So sometimes if somebody has like lymph node problems in any of their extremities, they have something called lymphedema. So edema, buildup of fluid from their lymph nodes. So their lymph nodes aren't able to function and filter as they normally would. And then everything from that point down starts to build up. So some people with like bad lymphedema, they'll have it like one leg just looks super swollen all the time. Also, whenever we start talking about like taking blood pressures on certain sides of the body, if somebody has had like a mastectomy, like one of their breasts removed from like cancer or something, a lot of times they take out these lymph nodes as well. And so you're not supposed to do a blood pressure on that side. You don't want excess buildup of anything, so you squishing their arm by taking a blood pressure can cause extra, like, lactic acid and stuff build up that their lymph node isn't there to help filter out. So, as you can see, our lymph nodes are everywhere. So most common ones known are like up in here, but they're really just everywhere. And then we have part of our organs. Our organs are part of our lymphatic system as well. So our adenoids, our tonsils, spleen, our thymus, and then our little nodes, which is what you see here. Don't do the blood pressure on the same side. Now, if they've had bilateral mastectomies, sometimes you just can't avoid taking a blood pressure on that side. But you can get blood pressures on legs and stuff, so if it's causing too much. Yeah. So here's our nervous system. I should have had Calvin in here, but he's at work though. Thank you. So our spinal cord is protected by our vertebrae, and then our nerves control pretty much everything. So this little graph here is something, each color is related to like what part of our spinal cord affects what part of our body. You can see like the purple thoracic is right in here. Our cervical is green, back of the head. Our lumbar is our legs, and then our sacral is the outside of our feet, our junk. So this is called our dermatomes. So DERMATOMES. So dermatomes, if somebody has like a spinal injury, let's say like here, from here down usually stops working if their spine is affected. So we're talking about like our cervical, our C3, C5 actually controls our diaphragm, our phrenic nerve. But if someone has like a high injury, everything from here down is just like, not today. Everything dilates. So all of our vessel, our tone of our vasculature just will like relax. So it's important to like continuously monitor patients that have like C-spine injuries, thoracic injuries, any kind of spinal injuries, because they will lose tone from that point down. So if I hurt my back like super high up, from there down is just gonna not respond to my brain anymore. And you'll actually see in some patients like that point down is a different color. Like their skin will be like red and flushed and weird. So it's really important to do a good assessment on your patients.
What did you say earlier? Like C5,
C3 through C5 keeps your diaphragm alive. So those are the vertebrae that are gonna, if you hurt them or injure them at that spinal cord, at that level of the spinal cord, your diaphragm will just stop working.
You were pointing at the screen, you couldn't quite tell on the video where you're pointing. So you might have to say like
Oh.
C1 or T5 or something.
Oh, okay, yeah. Thanks, CJ. I forget about that. All right, so our central nervous system is our brain and our spinal cord. And then peripheral means what? Away. Away. So if we, a peripheral nervous system is away from our spinal cord. So we have our sensory nerves. So if you're able to feel hot and cold, that's our sensory nerves. And then we have our motor nerves, which allow us to move things, right? So whenever, I don't know if you guys go into it, you know, but you have cranial nerves as well. So you have certain cranial nerves that are, that deal with like the movement of like your eyes, your lips, your face. And then there's some of them that deal with how you're able to perceive some kind of like, if I'm touching each side of your face. And then our autonomic is automatic. So that's all our involuntary motor functions. So breathing, digesting, our heart, all that fun stuff. Then we have our digestive system. Yuck. Honestly, abdominal problems are so difficult. So in EMS, like in their EMT classes, every EMT class you're going to take, they're like, yeah, these are all the little like tests you can perform to figure out what's going on in someone's abdomen, and they like put a huge emphasis on being able to like differentially diagnose your patients. I will tell you, when it comes to like the abdomen or the digestive system, Most of the time, you get them into the ER and most doctors are like, I don't know, run a CT on. They're gonna put a lot of emphasis on like, is it a gallbladder problem or is it is it a liver problem or is it this or is it that? And most of the time we don't know, right? So that's just how our digestive system is laid out. So we have our liver. It's a big organ. Which quadrant is the liver sit in? Right upper. Our gallbladder kind of sits a little bit tucked up under there. And our pancreas, does anybody know what illness or disease?
Diabetes.
Yes, thank you. So pancreas has a lot to do with our insulin release, right? So that's, someone had a pancreas. Gee, who has diabetes? And so our pancreas deals with all of our insulin and glucose storage and all that stuff. Then we have our spleen that deals with our, like it stores our red blood cells, so that thing bleeds like crazy. And then we have our appendix. So what quadrant is our appendix in? Right lower, yeah. And then our integumentary system. So our skin is our largest organ, right? So it protects us, obviously. If you go out in the sun, our skin's gonna protect us. It's gonna protect us from hot or cold. It's gonna do like thermal management. It keeps us the right temperature that we're supposed to be. It also balances water, so we sweat out of our skin. Excretion. So a lot of times with like, if you have somebody that has like really bad edema, sometimes it'll start like out as well, which is kind of yucky, but excretion. And then it's kind of acts like a shock pad, right? So our skin protects us from some injuries.
What's edema?
It's swelling.
Oh.
Yeah, so anytime where there's fluid where it shouldn't be, it's called edema.
And it can start to leak.
It
From
can
the
start to leak.
skin?
Yes.
Would
Yes.
that just be plasma?
Yeah, basically. It's like everything that should be intracellular goes extracellular, and everything gets really like pliable, and everything gets leaky. It's really good. Also, if your like kidneys stop working and you're not getting treatment for it, like dialysis, you can actually start excreting. It's basically urine. They call it uranic frost. You can start excreting that out of your skin as well. It's kind of yucky.
Would you smell like piss?
Honestly, like the patients that I've had that had it, they just smell bad anyway. So I don't know if there's a certain smell to it. Maybe. So we have our different layers of our skin. So our epidermis is the top layer. Everybody's epidermis is showing. And then our dermis is this lower or in between layer here. So we have a lot of like our glands, our vessels, our sensory receptors kind of sit up under here. And then our subcutaneous layer, that's where like our fat is, our major nerves, major veins, arteries, all sits in there. So if someone has an injury and you can actually see like their fat, it looks like that. Yeah. Oh, whenever you got your legs. Yeah, you can see like fat come out and it looks like that. It's like yellow and bubbly.
Really weird.
Very, very odd. It's like whenever you get like a piece of meat from the butcher and it still has the fat on it. Yuck.
What is the erector pili?
So that is right here.
Yeah.
If I remember correctly, it's what allows like whenever you get goosebumps, your hair to stand up and stuff. I'll have to confirm that. So our endocrine system, so our hormones that regulate our body functions come from our endocrine system. So we have our pancreas, our adrenal glands. So they secrete epinephrine or adrenaline, right? Everybody's very familiar with adrenaline or epinephrine. So that's a catecholamine. Our body makes that. So adrenal, that all comes from our adrenal glands. There are certain, like there's a tumor that can grow like on your adrenal gland that can make you secrete too much epinephrine. Don't ask me what it's called right now. I'll remember later in the shower. Right now I don't. Pheochromocytoma. I got it. So just know that there's like certain things that can act on part of our endocrine system that can cause a lot of problems, like with our hormones and stuff. Thyroid is another one. Thyroid's a very common one, especially like in older ladies. Thyroid dysfunction is huge. So yeah, this is also in your book. I think it's on those forms that I handed out as well. So we have our adrenal glands, our thyroid, our pineal gland lives in our head. Our pituitary gland also lives in our head. Ovaries, testes, pancreas, all that.
So the thyroid regulates regulates the metabolic rate and blood calcium levels.
Yeah.
So in elderly patients, like elderly women, why is that? Well, what's the response of non-working thyroid?
So you can have a couple different problems with your thyroid. You can have like an overactive thyroid. And so someone that has an overactive thyroid, usually they're really skinny. They're like, usually their heart rate like rests a little bit higher. And then you can have hypothyroidism, where thyroid is like underworked. And so a lot of times the people that have hypothyroidism have a hard time losing weight. They feel tired all the time. They can get like different cardiac problems because it's like calcium is one of the major like electrolytes that our heart uses to be able to function correctly. And so anytime that's messed up, it can cause a plethora of issues. I can't remember that actor's name. There's an actor on, I'll think of it. So it can also cause like bulging of the eyes. So it's called exophthalmos. There's an actor, and it's off of the show. Who's the guy that drinks white? What is this in that show? The Big Lebowski. Has anyone seen that? Who's the guy that they're like? Is his name Denny or something? They're like,
Yeah.
Shut up, Denny. And he has that. He has exophthalmos, like his eyes like bulge out of his head.
And that would be hypo.
So
he's got hypo.
Well, that's not always caused from that, but that's a sign that you'll see with that. All right, so our renal system. So remember, Ren has to do with like our kidneys, right? Our renal system. So we have our kidneys. The urinary system helps filter, right? We pee out anything that we don't need. If anybody's taken like a vitamin in here, like vitamin B12, and then pee like a fluorescent yellow, that's our body getting rid of excess that we don't need. So it helps regulate our fluid in our body. It helps with our blood pressure. We excrete like part of our pH and then our chemicals. It helps get rid of all the stuff that we don't need, and it helps keep everything regular. The nephrologist that I was talking about last class, this is their realm. They're like, you can't make them pee too much, or make them pee more, or whatever, because our kidneys regulate everything, keep everything in balance. So if you have a problem with the kidneys, you start to get a buildup of electrolytes that you don't need in your system. They can lead to cardiac arrhythmias. It can affect your blood pressure, like your renin, aldosterone, blah, blah, blah system is all part of your kidneys. And then we have our bladder. It stores the fluid. And then your ureters. So this transports urine from the kidneys to the bladder. If anyone's had a kidney stone in here, that's where kidney stones like to get stuck, in the ureters. So I've never had one, but I've had patients tell me that it's worse than childbirth. So I wouldn't wish it on anyone. And then your urethra is what excretes the urine. So here's just more pictures. So kidneys filters blood. There's little things in our kidneys called the loop of Henle, and they help all of that process go through. Certain medications can affect different parts. So like diuretics, the medicine that makes you pee all the time. So most of them work on like the loop of Henle, so you pee more. All right, the reproductive system. I think this might be, I like this little meme. It's funny. All right, so I think this is our last little section here. So male reproductive system, we have the testes. We talked about the vas deferens earlier. That's where they do like vasectomies. So they go in and they can cauterize this right here. So that's what like the semen goes through. And then there's seminal vesicles. This long word that I can never say, little porphyrial gland. Obviously the penis is part of the male, and then the prostate gland. And then the epididymis. I don't know how to say that. That stores the sperm. Yeah, the epididymis. That stores the sperm. So. And then the female reproductive system. So the breast produces the milk. Also, like whenever we start talking about like baby delivery, whenever we deliver a baby, we always try to have them breastfeed because it helps release chemicals in the uterus that helps the uterus contract and stop bleeding. So more chemicals, more hormones, but the breast is part of that. The uterus, the fallopian tubes. So remember, uteruses are not these huge, scary things. They're small. They're like the size of a fist. No, fallopian tubes, the ovary where the little eggs are released, and then the vulva and vagina. So obviously, if someone's having like a medical emergency where they're having like vaginal bleeding and it's coming from like the uterus, we're not going to be able to stop that, right? Oh. You walked in at the right time. But whenever we have something like certain kinds of trauma that can happen, you can still kind of stop some of the bleeding. But just know, like if it's up in here, especially after childbirth, we're not going to start. You never pack the vagina.
Mike. Mike.
Oh yeah, Mike's got to tell the story.
You're wondering how to stop bleeding.
Yes.
I had a question about stopping bleeding.
Yeah, vaginal bleeding specifically.
He's like, you told everybody last class.
It's not my fault. Let's start with that. It's not my fault. It's never my fault.
Now, mind y'all, he's gonna be teaching y'all's class in a couple weeks.
Yeah. So watch it, because I have to sign you off on CPR on Saturday. So watch. I was an EMT student once. Okay, long time ago, about 8 years ago. Had an instructor. She was very enthusiastic. Very enthusiastic. And so we're learning, right, about how to stop bleeds. And she was like, well, if you have a lady that has vaginal hemorrhage, like you take one fist and then you take two fists and you go up one side and then you clamp down on the stomach and push together to stop the bleed. Because how do we stop bleeds? We stop it with direct pressure. You're going to learn that in trauma, right? So I'm a brand new EMT. I don't know nothing, right? I'm like 7 weeks into class. I'm like, ooh, fuck yeah, I get it now. Like just a little bit of pressure, whatever. So I go and I do my ride time with Elko County Ambulance. Those guys are a lot different than we are. They're burnt out, they're old, they're tired, they get their shit put in the dirt, right? Like they are working triple time. So I get this lady, super nice, actually really like her, like solid medic. I still talk to her today. And we're going through these medications, and I don't know if you guys know about Pitocin, right? Pitocin is what they give females to induce labor and contract the uterus to stop bleeding. So she's like, what is this? And I'm like, oh, I know, right? It's for that. And she goes, oh, good job. And I'm like, yeah, and if a woman is bleeding out of her vagina, I'm going to take my fist and shove it up there, and then I'm going to fucking clamp down on the other side. And I'm like, okay, so I'm like, like, look at me. Like, I'm ready for my next attaboy. And she literally, I'm not fucking kidding you, dude. And I'm like 20, I'm probably like 22 at this time, right? She literally goes like this. She looks at me and she goes, don't move. I'm like, okay. She fucking gets up out of the ambulance, goes inside the station, and I'm just sitting there with another EMT student. I'm like, dude, 10 minutes later, she comes back and sits down and she goes, okay, listen, you will never, under any fucking circumstances while you are working with me, shove your fist in a lady's vagina. Do you understand me? And I'm like, yeah. Now, fast forward a couple of years, I'm working with her husband, who's also a paramedic. He'll be here Saturday too. And he goes, yeah, man, you wouldn't believe it. Like fucking Brittany was working and this fucking EMT wanted to shove a fist up a lady's vagina, and I'm like, damn, that guy sounds fucking dumb. That guy sounds fucking dumb.
And you
But-
said you're married?
And 3 kids.
Oh.
Yeah. It's all talent over here. So, yeah. First team all talent. We actually had to have the whole class got corrected the next week because every student that went in after that was like, yeah, we're gonna shove a fist in the vagina. So our head instructor, our like the big guy was like, listen, no fists, no vaginas, they don't go together. That's not a thing. They don't work together. Don't do it. So, yeah. Anyways,
And I guess whatever your kink, man.
listen, you got to stop the bleed somehow. That one didn't work. Right. Good work. That's the female body.
So listen, we were all in y'all's position, all right? We were all kind of dumb at one point.
I think I found
He was
out.
dumb enough to like not to do that.
Well, I mean, here's the thing, right? It's like you're taught something at some point in this career, it might not be that aggressive. Might not be that aggressive, but you're taught something, and that's why we have soapboxes, because people are taught things, and we're like, oh, that's stupid, we don't do that. But I guarantee you, you're gonna get out there in the goddamn mine site, or run around on one of these freaking ambulances, or run around somewhere, and you're gonna meet some freaking 30-year-old goddamn paramedic that's like, this is how you do things. And that's not. And it's a clear example of one of those people that's supposed to be teaching you something, and
Please.
don't
Please
do it.
don't.
Please don't. God.
There's only one reason I can think of that any part of you should go inside of a vagina.
In the back of the name.
In the back. Of course, of course.
I mean, or not in the back of the ambulance.
I mean, whatever
At least
y'all
the
are.
child support is messy.
Whatever y'all are into. So. On that note. Things to remember. So cellular metabolism. So what happens?
No,
No fist. Things to remember. Right here, big bold letters. Don't put your fist in the vagina. Please God. And then. What?
You lost track.
Honestly. All right, so cellular metabolism requires a constant supply of O2 and glucose. So this comes important later when we start talking about the brain. Our brain needs glucose. What is glucose?
Sugar.
It's sugar, yes. So absence of either component disrupts normal metabolism. So all of our cells everywhere need O2 and glucose and other things, but that's the big thing. Yes.
Will a diabetic have a problem producing glucose in their brain? Would that make sense?
Yeah. So a lot of times it's like the metabolism of glucose. So glucose gets in our system and it gets into our bloodstream. And from our bloodstream, it has to get into our cells to be functional, like to work. And so what diabetics have, they have a problem getting that glucose out of the intracellular into their cells so that cell knows what to do. And so depending on what kind of diabetic you are, you might need like insulin, or you might just need help producing insulin, but that insulin is the key to get that glucose back into the cell. And if that glucose is not in the cell, the function, it's not going to get to the correct parts of your brain. That makes sense?
Yeah. That's why they go all crazy. But there is actually and I don't know the exact name of it, and I wouldn't be able to remember it even if I wanted to. There's actually a disorder where the only part of the body that won't metabolize glucose is the brain. And they have to go in. What?
It's like central nervous.
I put myself on the spot, I can't tell you, but I do know what the freaking issue is, but I can't tell you the word for it, but there's an issue where basically your brain can't metabolize the glucose, and they have to do like spinal tests to go in and like check for that. It's like it's really rare. It's a hard thing to come across, and it gets misdiagnosed as a lot of things before they get to that point. And we actually had there's a girl in Atlanta, and I wish that I could reach out now and figure out what she had, because I'm pretty convinced that that's what she had. Because she would go into like these seizures that we couldn't stop and nobody could get to stop, and they were just like continuous, and that's one of the side effects of somebody that has this issue, because their brain just won't metabolize that glucose appropriately, so.
Because you can have a lot of glucose in your system, but if it's not getting utilized in the right places or getting where it needs to be, then you can have a lot.
Yeah, her sugar would still read normal, but it was like just the brain won't metabolize it, so.
Very rare. It's not something that you're gonna see and diagnose like day one of BMT, you know?
No.
It's like one of those things that you sit there and scratch your head like, what is going on with this patient? We did all the things and nothing's happening, and then later on you're like, oh.
Yeah, some doctor tells you that that's what's wrong with it, and you're like, crap, I mean, you couldn't do anything about it.
So, cardiopulmonary system combines the functions of breathing and perfusion, so respiratory and cardiovascular systems provide oxygen at the cellular level. What is this called? EQ. EQ match, right? The BQ match thing will come up later. That's what I'm trying to get in your brains now. Ventilation, perfusion. So a shock occurs when the cardiopulmonary system fails and cells become hyperperfused. So whether it is the cardiac part of the system failing, or the pulmonary part of the system failing, or the vasculature failing, either way, any of those things can cause shock. So for some reason, the cells are hypoperfused, their body's like, what questions? Yeah, sorry, I get excited when I start clicking.
In the nervous system, you spoke about
Dermatomes.
Yeah.
Yeah.
What were those again?
So those are the level in which that part of your spine is talking to the rest of your body. So they all have different parts of the body that they talk to. I probably should have just clicked on the last slide.
And all this stuff, so this is, like we said earlier, this is like an overview of everything. And then if you look through all the chapters, there's like the respiratory chapter, the nervous system chapter, the pulmonary chapter, like each chapter goes more in depth, because we'll talk about those things and then disease processes that go along with those things. So seems like a lot, it is, but it'll start clicking. It's fun to like teach this side of it, because there's like a certain point in each one of those chapters that things start like clicking from like all of this crap that you're like, oh, that makes sense now. So don't over stress, because there's a lot more in-depth chapters about all of these systems and all these processes.
That's the fun part of teaching. Like I'll watch your guys' little light bulbs go off. And I'm like, yes, it's whoever you.
What's the next chapter we go over? What's 7?
Respiratory. Also, if you guys want to see what these PowerPoints look like, go forward.
So keep this in mind, right? This one's 49 slides and like fun and interactive.
Gonna give us a sneak peek.
This is why I said on like day one. This is why I said on day one, if I catch you cheating, I'm gonna thump you in the head with this freaking golf club. Because her in particular, I deal with the backside, I deal with like all the electronics, I deal with all the tests, I deal with all that stuff. She deals with these PowerPoints. And she has put a full-time job into recreating these PowerPoints, because this is what they all look like.
All of them look just like this. They're
And
like
this is 105 slides. So instead of the 49 that we did today, this is what we would be going through instead. So y'all can thank her. I only made like 4 of these PowerPoints. And they're like the very end. Yeah. I only made like the very end, which is like hazmat and vehicle extrication and stuff like that. Because Becca's like, oh, about freaking another car. I'm like, I can do that one. So, yeah. So, yeah, just keep that in mind. This is what we could be doing and what most places do. This is what my paramedic school is like.
Every single EMS class that I've ever taken, they're like, we're gonna make this not death by PowerPoint. And they pull these up and I'm like, this is still death by PowerPoint.
Yeah.
So I tried to really not give you guys death by PowerPoint.
No, it's nice, you can also go back and see, because with you clicking, I'm only on and you're already on 10 slides after that.
Shit. I did slow down the clicking, I'm sorry. I get excited, you know, the clicker's fun.
Oh, it's fine, it's just rewriting some of the stuff.
Yeah, and if at any point in time, y'all are at a point like you did where you're like, hey, can you go back to this? Like, I want to write this part, like, just let us know.
Also, we had someone last year that like wanted printouts of the PowerPoints, and that's fine too. Like, if you want printouts, just let me know before class.
But if you give them to one of your teachers, help them. Because people like to steal freaking PowerPoints. So,
But if you want like notes to take along,
we
No, it's
did.
just like when you printed this stuff off of the skull, stuff, that really helps out.
Cool.
Too.
Good.
I was actually trying to look something online for that.
Yeah.
We try to make things
There's,
fun in there.
Oh, I did have one question. So like, with the spine, it has like little blank spots to fill in, but there's nothing in the.
Oh, yeah. Don't worry about the bottom half of that spine thing because the blanks got put in the wrong, yeah.
oh,
The blanks got put in the wrong spot on the bottom half of the spine. And so the answer's already there for you.
yeah.
Yeah.
I was just testing to make sure you guys were paying attention. That's Mikey's fault again.
Yeah, we'll blame Mikey. Yeah.
That's wild. There should be, there's another website.
Trust me, that is not, if I had a freaking dime for every dumb story I've heard in the last decade that I've been doing this.
Yeah, I was taught like standing takedowns. Mass pants were like just getting out of favor when I started EMS.
Mass
Mass pants.
Yeah, it's freaking like balloon pants.
Yeah, so there are these like pants that you put on your trauma patients that have low blood pressure. And their theory was if you blow these pants up, that it's gonna push all their blood from their legs into their vital organs. And then they're like, oh, actually this doesn't work.
It doesn't work at all. It's probably all the departments that just get the crap out of people, so.
Yeah,
we
but
probably stop doing it.
California came out with this new thing. Why? Where they're basically mass pants, but they're not like big pants. They're like little compression socks that you roll up on the patient.
We don't follow California.
Here's
Thankfully,
something-
California's a beautiful state, but they're taking on medicine.
Yeah,
Their take on medicine is rough.
yeah, it's really rough. So this is another website if you guys want to write it down. If not, it's fine. This is kind of that same theory, like you can label the heart. So left pulmonary arteries. Let's see if I can find it. So you click on, so it tells you right here, bicuspid valve or the mitral valve.
Purpose games?
Yeah, and so there's a bunch of them on here.
Wrong.
That was wrong. Oh no.
That was wrong.
Can't see.
Put you on the spot.
Oh my goodness.
Wrong.
That one.
Which one is it? I can't
No.
see what you've already clicked on.
Negative. There you
Okay,
go.
got it. Semi-linear valve. Yeah, I would put this one.
It's somewhere in there.
Where is this pointed to? Right here, this one?
Yeah, that could be.
Okay. Yeah, so there's little fun games on here. I think, is that pointed to the little cord? Was that a happy noise?
No.
Oh, there it is. It's hard to see from over
Yeah, it's
here.
hard to see the freaking things are pointing.
Yeah, papillary muscle, that's gotta be decent. That one. Good. So anyways, fun little ways to play
You
label
can
the
like
heart.
rate some, like green, red, or orange.
Yeah. So we played this with our last class, like towards the end when we were just studying. We have a big Promethean board, it's a big touch screen. And so we had them in here seeing who could get it the fastest. It was fun.
We do tourniquet races in a couple weeks.
Yeah. We have Jeopardy. I make Jeopardy games. There's a website where you can play Jeopardy or make your own Jeopardy game. So
There's prizes for people that can beat me and Mikey in tourniquet races. Putting 4 tourniquets on, putting one on, well, one person gets 4 tourniquets. So you get a person on each side and you put a tourniquet on a leg and a tourniquet on an arm. Whoever can do it the fastest correctly wins.
Since you're down or no?
Huh?
Since you're down or no?
Oh, yeah.
yeah,
Yeah, put it on appropriately.
Timestamp?
their
Yeah.
extremity has to be pulseless by the time you're done.
So if you can beat me, you get a prize. Can't warn you though. I'm quick. Nobody at this station's beaten me yet, so. I also have awards for putting on the most tourniquets in Atlanta, so.
Cool. Does anybody have any more questions? Huh? Okay.
I want to know what's going on. So I can breathe fine, right?
Okay.
I have this stuff, so I can take albuterol.
Okay.
I don't know if I actually have asthma. My doctor is just like, you probably have asthma.
Mhm.
So, but I can't stop yawning. So then I'll hold my breath. When I hold my breath and then I exhale, I feel better. But then I feel like I faint.
Why do you feel like you're gonna faint, or why do you hold your breath?
But why does that help?
Why does holding your breath help?
Yes.
This is my theory. I'm not a doctor. I don't know.
Right. Because it's not something I go to the doctor.
Yeah. So we have something in our aortic arch in our brain. They're called chemoreceptors. So they're always sitting there taking little samples of your blood. Like how much CO you got in there, how much oxygen you got in there, when do you need to breathe? And they talk to your brain and say, okay, breathe now. So if it reads capnia, so hypocapnia. It probably reads your little chemoreceptors are probably like you're hypocapnic. So you don't have enough CO in your system. So then when you hold your breath, that CO builds up. So then it's like, okay, we can breathe now. And then it like releases. But getting dizzy is just lack of oxygen, I would assume. But I don't know. That's interesting.
It's not the guy that taught our EMR class too. They run away.
Yeah, because our body's like, have you ever like tried to hold your breath for a really long time underwater or whatever? Have you ever tried to hyperventilate before you do that? So you sit there and like hyperventilate. You get all your CO out of your system. It's called a nitric wash. So you get all of the oxygen, you hyper oxygenate yourself, and then you blow out all your CO2. So your CO2 goes down, your oxygen goes up. So those little chemoreceptors wait longer to tell you, okay, you need to breathe now, because it takes longer to build that up rather than if you just take one big breath right now, you don't have all that. That's my theory, but I don't know. I'm not the doctor. We can ask Dr. Calvin when he comes back.
Lifeguards on duty, please. Go to the floor, maybe that.
Yeah, I don't know. That's interesting though, for sure. I know our bodies are weird when it comes to like what chemicals are in our blood or not.
Like the albuterol helps, and I'll stop yawning, like I'll be able to
Yeah. So you ever been like wheezy or anything?
easy,
Like your lungs, can you hear yourself breathe? Like,
no, I can breathe fine.
interesting.
Sometimes I think it's just a little head game. Like
Maybe. Well, because albuterol does more than just open your vessels in your lungs. So it's something called a sympathomimetic. We talked about, well, we haven't talked about it yet. We have a sympathetic nervous system. So that's what our fight or flight response is. Our little nervous system goes off and is like, you need to run now. But anything can send you into like a sympathetic system. Someone knocks on my front door too hard and I go into sympathetic, right? So albuterol is a sympathomimetic, so it mimics our sympathetic nervous system. So when you take albuterol, not only do your airways open, but your heart rate goes up as well. So I almost wonder if you're not like pushing more
That would make sense with the yawning
blood
symptom,
through.
because yawning would be the opposite of that, right? 'Cause
Maybe. I don't know. Some people yawn when they get nervous or anxious. That's just like they're coping.
But that's like a like a tick.
I don't know. There's a lot of factors at play here. And I'm not a doctor.
I don't want to go to a doctor to tell me that I'm fine. You know?
Like, but while I'm in this EMT class.
Yeah, that's like one of those things you'd have to see like some random specialist that studied their whole life for this one thing. Yeah, I've been studying my whole life for this. Yeah, I don't know. That's interesting. Yeah, yeah. Like these people that study their whole lives to figure out like one disorder, and like 2 people in the world have this disorder, but they're specialists in it. So. Yeah, very interesting.
Time to make this baby and head out.
I don't know if y'all want to. I didn't even go over today. That's pretty good. So yeah, any more questions? Feel free to ask.
Whenever we turn in that ambulance ride thing, as long as we have a CPR card, we can ride, right?
Yeah, so I think March 1st is gonna, well, you can ride along before March 1st, basically. So as soon as we get our CPR, are you talking about submitting it online?
Yeah, I already have one.
Okay, yeah,
Oh, you
you
got
should be
yours
good
back?
to come ride along. I think, we're waiting till like March 1st to start counting the hours, just because, that's whenever you're gonna get through like the bulk of the stuff. So you can see what's going on and like know what's going on. But you're free to come right along at any point if you have until then. Yes, if you have your provisional license, you can practice in the back of an ambulance. If you don't have your provisional, you're free to come ride, but you just can't touch patients, can't do all that stuff.
What all do we need to do? Because I'm honestly
Just, so you go to the state website and then you apply. Don't fall. You'll apply for a provisional license and then that, yeah.
Yeah, you'll apply, it's at the bottom. We'll go over it again on Saturday for the people that haven't applied for it yet, that don't have their CPR card. We'll go over it again on Saturday on how to do it. And then, everybody can submit it. It's pretty easy to do the provisional. And then everybody can submit it, and then we'll start riding along, like she said, around the 1st of March, probably. And then I'll print off a big calendar, and to make it like somewhat fair for everybody, we'll go through and like let everybody pick days, and then, you know, pick what days they're available to come ride, and then we'll build a calendar off of it, so.
So you said 24 hours we have to ride?
Yeah, so you can do it in 2 12-hour shifts. If, we prefer daytime, just because that's when we're the busiest. So we prefer 2 12-hour days, and because then we can like take you over to the ER, you can do stuff in the ER, different things like that. Because I'm not going to the ER with you at 2 a.m. so that you can look at somebody because their foot hurts. So I say that as politely as I can. But during the day, I'll go over there with you at 2 p.m. because somebody's foot hurts, but not at 2 a.m. So, yeah.
Yeah. Yeah, and you're able to use like any patient contacts in the ER. If someone walks in and you do an assessment and vitals, and the nurses over there will let you, you can put those towards like your patient contacts. So I recommend it.
So if we go and ride with a different ambulance service?
So I have to get approval for it to count towards our class, and I'm gonna reach out to Tony in Humboldt. I'm not sending y'all to Elko, respectfully. I don't know if anybody lives in Elko. I don't agree. Oh, well, good thing she's the only one, because I have personal beliefs about how they do things in Elko. and how they mistreat students in Elko, so I'm not sending anybody to Elko. I will do Humboldt if I can get the paperwork with Tony. We tried last year, we were having some scheduling issues, but if I can get the paperwork with Tony, then Humboldt should be free to ride with. So it'll be between here and Humboldt. And just, I have things against Elko, so I'm not sending folks to Elko.
Do they have to be 212s or is it only correlated, like it came before class or something? Like 95 or something?
Yeah,
Well, and you
so-
can ride during class too, so.
Yeah, so you can do that. It's just with everybody, getting everybody all within a few months, their 24 hours, we'd have to figure out how that worked. It's not a first come, first serve. Like we'll give you guys a schedule, you write what days you're available to ride, and then we'll assign you those days. So it's not gonna be like every day you put on, you're gonna be able to ride that day. You might, but that's not always the case.
So some of us have our CPR cards and there's a call during the CPR class, could we possibly?
So here's the thing that I have to preference with running calls during class. If you're running calls during class, I can't count the hours that you're gone. So if we're going for 2 hours on a 911 call and you come with us, I can't count those 2 hours that you're gone. So just understand that if you sign up for a Saturday and we're just getting hammered all day and you're supposed to be in class and we were on 911 calls for 6 hours, that 6 hours is just going to be lost for that Saturday unless you make it up later.